Hi, my name is Dr. Melissa Teo, a general surgeon and surgical oncologist specializing in gastrointestinal cancers, sarcomas, melanomas, and peritoneal disease. I was the ex-head of the Division of Surgical Oncology at the National Cancer Centre Singapore before I left to set up my own practice at MountElizabethHospitals. Today, in our series on cancers in women, I will be focusing on secondary cancers and in particular, colon and rectal cancers. Breast cancer gets a lot of attention and is always in the limelight because it affects women from young to old. We have so many successful campaigns that highlight the importance of breast cancer screening, and the pink ribbon is recognized by everyone. But what about the other cancers? As seen on this chart, colorectal, lung, uterine, ovarian, and stomach cancers are amongst the top cancers in women, but do not get enough attention. Cancers are common, and I want to highlight that people are now surviving their first cancers long enough to get a second cancer. In fact, many will survive their first cancers but succumb to their second, which is why it is important to be aware of what the potential second cancers are. Many may ask, why would a person be so unfortunate as to get two cancers in their lifetime? But the truth is that some of these risk factors that resulted in the first cancer are common factors that result in the second. These common risk factors include genetic susceptibility, environmental and lifestyle exposure, hormonal factors, infection, and carcinogenic effects of the previous cancer treatments. Who doesn't recognize this face? Angelina Jolie brought hereditary cancers into the limelight when she opted to go for a double mastectomy prophylactically. This means that she had her breasts removed even before she developed any cancer in them. A few years after that, she also had her uterus and ovaries removed. And the reason for that is because she was found to have a genetic predisposition to developing cancers in these organs. BRCA, BRCA, Lynch, and Leigh-Ferroni are common syndromes that result in increased risk of cancers. On this slide, you will see that in Lynch syndrome, a woman with colorectal cancer would have a much increased risk of having uterine or even ovarian and stomach cancer. Conversely, if she has known Lynch syndrome and has been diagnosed with uterine or ovarian cancer, we must be aware that her risk of colorectal cancer is markedly elevated, and we should in fact screen for it. Many in the audience may think it would not affect them. I mean, how rare is something like Lynch syndrome? Well, not that rare. 1 in 300 people in the United States has it, and hence they are at an increased risk of all these cancers that you see on the chart. Patients with Lynch syndrome require a colonoscopy every 1 to 2 years, a pelvic examination and ultrasound every year, and even screening for stomach cancers with endoscopy. But let's turn our focus to colon and rectal cancers, as these are very common. And in fact, colorectal cancer is the commonest cancer in most countries and the second commonest cancer in women after breast cancer. I like talking about colorectal cancer, not just because I treat a lot of people with it, but also because colorectal cancer, I feel, always gives us a chance. They start from a small little polyp, and that takes years to become cancerous. So at any point in time, it allows us a chance to nip it in the bud by the removal of these polyps once they are present. Polyps are common even in the general population. This slide shows polyps of varying sizes, with the small ones easily removed by either a hot biopsy or using a snare. When they are left for a long time, they grow, become harder to remove endoscopically, and if left for long enough, can become cancerous. You will see here that this is a specimen from a typical person with a propensity for the formation of polyps, with one of the polyps having become a cancer. If it had been removed when it was the size of the 2 polyps that you see in the specimen, this patient would not have developed cancer. We mentioned risk factors for the development of secondary cancers earlier on, and this slide highlights again, of course, the other risk factors for colorectal cancer, such as age, gender, previous history of polyps, and certainly lifestyle factors such as smoking and alcohol intake. Of course, diet plays an important part too, and many societies are seeing an increase in colorectal and other cancers as we increase the meat and fat consumption in our daily intake, and we reduce vegetable consumption. The lockdown has made it worse for so many people, becoming more and more sedentary, and I for one can vouch for the fact that I've watched a lot more Netflix during this lockdown than before. Colorectal cancer can present with very alarming symptoms like blood in the stool, a change in bowel habit, loss of weight or appetite, but it can also be insidious without many or any of the symptoms. It is important to be vigilant and not to ignore symptoms, dismissing them as due to piles or something less serious. That is common in my practice. A colonoscopy allows us to visualize the colon and the rectum well, and allows us to take biopsies of any masses seen to come to a definitive diagnosis. It also allows us to remove polyps at the same sitting. The treatment of colorectal cancer is dependent on the stage of the disease. As with all cancers, there are 4 stages: stage 1, 2, 3, and 4. We stage patients typically with CT scans which can determine if there are metastases, and that means spread to other organs. A PET-CT scan is also another scan that we can do, being a metabolic scan that picks up any area with high activity. Now, for rectal cancers, MRI are particularly useful for looking at the pelvic anatomy and for determining the extent of the tumor and what it involves. Early stage cancers are easily cured and often require only surgery and no other treatment. Surgery for colorectal cancer can be minimally invasive through a laparoscopic approach or through open surgery, depending again on the extent of the tumor. When a cancer is at an advanced stage, then other modalities like chemotherapy and radiation therapy may be required. This slide shows the organs within the pelvis, and it is important for a few reasons. Firstly, rectal cancers can involve the surrounding organs such as the uterus, ovaries, bladder, and even the sacrum. Secondly, sometimes this rectal cancer is a secondary cancer, and a previous surgery in the pelvis may already have been undertaken for the first cancer, such as removal of uterus and/or ovaries. This first surgery would have resulted in adhesions, which is scar tissue, making the second surgery even more complicated. Thirdly, the first cancer that the patient may have had may have already necessitated treatment with radiation, which once again makes surgery in this area a little bit more hazardous. In fact, radiation treatment for the first cancer may pose as a risk factor for the development of the second cancer, as seen here on this chart, which is not to say that we don't give radiation where it is required and has been proven to be effective in the treatment of some of these cancers. It just means that we have to be aware of the risk. Most importantly, if one were to have surgery undertaken in a previously irradiated field, my best advice would be to find yourself a great surgeon. In stage 4 colorectal cancers, other organs like the liver, lung, or peritoneum may be involved. Now, the peritoneum is a layer that lines the abdominal cavity and is commonly involved when the main tumor is advanced, causing obstruction or perforation. In many situations, potentially curative treatment can still be possible if the metastasis or the spread is isolated, and resection of all the disease may be possible. Here we have an example of a single liver lesion seen on the scan, and a laparoscopic resection of this lesion is being performed as seen on the top right-hand corner. On the bottom right-hand corner, we see a diagram of our setup for HIPAC. HIPAC is a treatment used for patients with peritoneal disease from colorectal cancers, stomach cancers, ovarian cancers. HIPAC stands for hypothermic intraperitoneal chemotherapy, which is essentially installation of hot chemo into the belly after we have removed all the peritoneal disease. The chemotherapy is heated up as it increases the killing ability of the drug, and it can be given in high concentrations into the belly without the toxicity that you see sometimes when the chemo gets into a bloodstream. But I want to end off with a much more proactive approach, as I feel that we can do so much more to stand up against cancer. Screening for colorectal cancer means having a check before one develops any symptoms, and you can see from this chart that patients who have been screened have a much higher chance of survival than those who do not get screened. There are many modalities for screening, starting with a stool occult blood test, where the stool is analyzed for the presence of any blood. And a CT colonography is like doing a CT scan, but if I may say so, a lot more uncomfortable, as it requires still bowel preparation that one uses for the colonoscopy, and one would have to be pumped up full of gas so that any small lesions can be visualized better. In both the stool test and the CT colonography, One would still require a colonoscopy if there were a positive reading in any of these tests. A colonoscopy is a procedure where a small tube with a camera is inserted through the anus for direct visualization of the entire colon and rectum. This procedure is typically performed under sedation, and polyps seen can be removed at the same time, and biopsies of any abnormal masses can also be done. So who should get screened? Well, in very high-risk individuals, screening can even start in their teenage years. For example, those with a known history of familial polyposis syndrome, and in their 20s if they have Lynch syndrome. In general, those who have a family member with colorectal cancer should start their screening 10 years before the youngest age of the family member was at their diagnosis. For the average person, the guidelines advise screening from 45 to 50 years, and I would say most doctors have come to see me for their screening once they are above 40. So in summary, today's segment on cancers in women tell us to be extra careful even in those who have survived their first cancers, as second cancers can be deadly. We should give colorectal cancers their due attention, as they are often linked to other female cancers and are also very common in their own right. We do not need to give them a chance to develop, and so get screened and have these polyps removed early rather than late. In the event that does not happen, we are fortunate to have the technology and ability to treat a spectrum of early to late stage cancers. I thank you for your attention, and I've left my contact details here, so please feel free to reach out to me if you have further questions.